autologous blood donation performed pre-operatively in the operating theatre or anesthetic area. It is usually restricted to patients in whom the substantial blood loss is thought to be more than 20% of the blood volume is predicted. Whole blood about 1 to 1.5 liters is removed, and simultaneously intravascular volume is replaced with crystalloids and colloids to maintain the blood volume. The anticoagulated blood is then reinfused during or shortly after the surgical blood loss has stopped. This is done because it reduces the red blood cell mass lost during the surgical bleeding. This is most commonly used practice. So, it is the removal of the whole blood from a patient just before surgery and transfused immediately after surgery. It is also known as pre-operative hemodilution. So, the blood collected in such a way, there is no requirement of testing, no requirement of cross-matching. The collected blood are stored at room temperature for up to 8 years. If it is not utilized within 8 years, then it has to be stored in refrigerator in 6 degrees centigrade, and it cannot be used after 24 hours. Reinfused units and this acute normovolemic hemodilution is equivalent to pre-operative autodilution in some cases of radical prostatectomy, knee and hip replacement. So there are some clinical studies conducted on this, and compared with the pre-operative autodilutions, and it showed there is equivalent to pre-operative autodilutions. Is minimized cost because it doesn't require any cross-matching, any testing. Elimination of waste of units because it's immediately transfused. There is no there's minimal chance of wastage of units. No inventory or testing. There is nothing like no record is required. Never leaves the patient's room. Is always will stay with the patients and is transfused immediately. So criteria for the selection of the ANH. So likelihood of transfer, any cases with likelihood of transfusion exceeds 20% of the blood volume, then pre-operative hemoglobin of at least 12 grams per day, then absence of coronary, any organic disease like coronary, pulmonary, renal or liver diseases, absence of severe hypertension, absence of infection or bacteremia. So these cases are suitable for ANH. The indications of ANH, this HCT should be more than 34%. Intraoperative blood loss is approximately, it is calculated, predicted more than 1 liter. Any type of surgery with significant blood loss when the blood can be drawn after anesthesia and transfused. So, what are the post-operative concerns following ANH? There is chance of fluid overload, high blood loss procedures, and excessive hemodilution. Now the third category of autologous blood donations, that is peri-operative cell salvage. So it could be intraoperative, it could be post-operative. Intraoperative pieces, these two are least less used because these are costly and these devices are required, and it requires and the hazards are more. So these two conditions are less commonly used. The intraoperative RBC salvage, it entails the collection and reinfusion of the blood lost during and after surgery. The said blood is aspirated from the operative field into a specially designed centrifuge. Then citrate or heparin anticoagulant is added, and the content is filtered and to remove the clots and bleeding. Then the centrifuge concentrate the salvaged red cells and saline washing may be used. This concentrate is then reinfused. The devices are available starting from the basic instruments to the highly sophisticated instruments. And post-operative salvage refers to the process of recovering of blood from wound or drains where there is loss of blood approximately more than 10% of the blood volume. Then it is collected and reinfused the collected blood with or without washing. Now coming to the cost of this autologous blood transfusion. So there are several studies are there. the comparative cost data on various forms of autologous blood transfusion and the cost effectiveness compared allogenic with autologous blood transfusion are rather subjective and inconsistent. The many studies are conducted and they have concluded that the allogenic is more cost effective than autologous blood transfusion because the increased cost, it comes from unused autologous collection if it is discarded, magnified by over collection and unnecessary utilization, and by the extra work involved in the deviation from routine large scale allogenic collection practices. So some studies they have shown that if we do all these infectious disease markers cross matching it like normal allogenic blood donation, then it will be costly. But some other studies also show it is autologous blood donation is less costly or cost effective by considering the direct cost of the accruable for each unit of allogenic blood transfusion. This is particularly they have shown in the small scale hospital where there is some policies and strictly it is followed, and where the cost is cut down in two levels, like the infectious disease testing is not done in autologous blood bags and compatibility testing is also not done. So if we cut down these two costs, then it becomes cheaper than the allogenic blood transfusion. So to conclude, so this is a teamwork. So an autologous blood transfusion programs must be reliable, effective and safe for patient and practitioners. A hospital wanting to establish an autologous blood transfusion service requires the total commitment of those involved. The essence of success is motivation and communication, and the planning involves all key players. It is quite likely that many of the patients will appreciate the value of autologous transfusion.